Welcome, everyone. Thank you so much for joining us today. My name is Colleen Christensen. I work with the Lung Cancer Initiative as the engagement coordinator here. And we're excited to have Dr. Yang and Dr. Jarrett Johnson to join us for this community education webinar on research updates in lung cancer. So I just want to cover a few housekeeping items before we get started. This is a recorded event, and so we will be uploading this recording to the Lung Cancer Initiative YouTube channel, and we'll be sending that link out to you all towards the end of the week. So feel free to watch this recording at a later time or share it with friends or colleagues that you think may be interested afterwards. If you have any questions throughout the program, please put them in the Q&A box down at the bottom of your screen, and we will be taking questions after both presentations have finished. And I think that's all I have to share. So I'm going to pass it off to Paige Humble, our Executive Director, to give a welcome and introduce our speakers. So take it away, Paige.
Thank you. I'm going to share my screen. I've got a really brief slide presentation here. Let's see. I'm beginning. There we are. Can everybody see my screen here? Good. Oh, excellent. Well, it's so great to see you all. I was looking in the chat and looking at everybody joining us today, and we are really, really thrilled to be able to see everyone today virtually. I want to thank Jenny and Colleen. They lead our programs, and they are helping us bring this programming to you all virtually. And, we look forward, hopefully later this year, to be able to do some of these types of things in person, but so glad that we can all convene in this way. I also want to thank our sponsors who make our community education programs possible. We thank them so much for their support. And I also want to thank you all again for being here today and for being advocates and taking this opportunity to learn more so that you can go back in your own communities and advocate for the cause. So I just have a few slides about Lung Cancer Initiative, and if you're newer to our organization, want to tell you a little bit about who we are and how you can get involved. Our mission is to advance survivorship and provide support to those affected by lung cancer through research, education, and access programs. So when we talk about research, we fund research fellowships in communities across the state. And we also have a career development award and an innovation grant. And our goal through our research fellowships and our career development grant is to find researchers earlier in their career in the hopes that they will stay in the field of lung cancer and continue to go on and do more research in the field. And our innovation grant is a way that we can partner with institutions outside of academic medical centers and work in the community on innovative approaches to lung cancer research. We also have survivorship programs, and those have continued to grow and evolve. And I will say the pandemic, as difficult as it has been because we can't connect, it has also opened new doors for us as far as ways to support survivors. We have monthly survivors luncheons, and we have been meeting virtually since the pandemic started. And I think we've found that has been very well received. And so we plan to continue those and hopefully continue to grow that program. We have a wellness retreat for survivors. We've been doing that for several years in collaboration with Wind River Cancer Retreats. And last year we did a virtual one, and I think folks enjoyed that one. Even though we weren't sure what to expect, it was a great opportunity, and we'll plan to do a retreat again this year. And we also have a number of other educational programs like today, where we encourage survivors and their loved ones and advocates to come together to learn more. Access, we have a gas card program. So we provide $50 gas cards to help patients access appropriate care and treatment. We have been able to reach patients from 2017 to 2019, we reached patients in 93 out of 100 counties in North Carolina. And I think last year, we reached upwards of 60 counties in North Carolina in just 1 year. And we also launched our patient stipend fund last year. As a result of COVID, we provided $250 stipends to help 80 patients just in accessing their basic needs during the pandemic. And we became very aware that this is certainly an ongoing need and is certainly a program that we hope to continue. And then we also have our REACH grants, which really support community institutions who are doing something to support access to screening, to research, to treatment, to education. And that program, we have up to 3 grants that we give each year for that program. I mentioned education, events like today, but we also have our summit, and that's coming up in May. And that is an opportunity for folks to come together, arm themselves with the latest knowledge about lung cancer, and to learn how to use their story to more effectively become advocates in their own communities. And so I really hope you'll join us for that event. It will be virtual this year. And so I've got some important dates for you. The very first one is the Advocacy Summit. It's Friday, May 21st and Saturday, May 22nd. And Jenny, is registration open for that already online? It is. So you can go find that on our website today and go ahead and register and reserve your spot for that event. This year, it's all about advancing survivorship. So we really hope you can join us. It's a great way to become integrated in the lung cancer community in North Carolina. We also have a Survivors Day celebration, which will also be virtual this year. Definitely encourage you to join us for that event. And then we have several other events coming up. One I want to mention is our Lunge Forward series. That has historically been an in-person event in 3 different areas in Charlotte, in the Triad, and in the Triangle. And this year we have moved the events, which have normally happened throughout the year. We've moved them all to one date in September, on September 18th. We are planning in-person events in those 3 areas on that date. And we also have some community events that are kind of popping up around the state too. And so if you are interested, if you maybe don't live in one of these areas and you're interested in doing something in your own community, reach out to us, because we would love to share with you how you can do your own Lunge Forward event in your own neighborhood, or however you feel comfortable wherever you live. We also have a golf tournament coming up at the Washington Duke Inn here in the Triangle. And our gala this year is going to be in November. So historically, this event has been in April. And of course, the pandemic has caused many challenges there. So we are planning for an in-person event on November the 6th here in Raleigh. And we are continuing to monitor CDC and public guidance. But our committee met just yesterday, actually, about how we can start safely planning for an event in November. And I mentioned our Survivors Luncheons, but I do encourage you to check out our website where you can register to participate in these lunches. They're on Zoom, so you need to register so you can get the Zoom link. But do reach out if you want to learn any more about any of these or any other ways that you may be interested in getting involved in the Lung Cancer Initiative. We're able to do what we do because of the volunteers and advocates that carry out our mission across the state. And with that, I am very thrilled to introduce our speakers today, both of whom have received funding on projects that they're working on through Lung Cancer Initiative. And so today we'll be hearing from Dr. Lee Yang. He's Associate Professor, Graduate Program Director, and IDP BBC Biomedicine Concentration and the Departments of Internal Medicine, Anatomy, and Cell Biology and Chemistry at the Brody School of Medicine at East Carolina University. And Dr. Leanne Jarrett-Johnson, who's the Assistant Professor of the University of Virginia. So without further ado, it's my pleasure to first turn it over to Dr. Yang.
Thank you for the introduction, and let me pull on my slides. Can you see my slides? Good. Again, thank you very much for the opportunity to talk about our research on identify biomarkers and therapeutic targets to mitigate immunotherapy-related adverse events. Surgery, radiation therapy, and chemotherapy are the 3 pillars for cancer treatment, and now immunotherapy is considered as the 4th pillar for cancer treatment. The history of cancer immunotherapy can be traced back to the 19th century. Initially, researchers observed an association between tumor regression and skin bacterial infection in some cancer patients. And William Cullen is a pioneer in this area of research. He injected bacteria, streptococcus, into sarcomas and observe some tumor regression in some patients. And he further developed like a regimen called like Colon's toxin by mixing inactivated bacteria, Streptococcus, and Syringia bacteria, and then inject those Colon's toxin into sarcoma patients and observe like some regression of tumors. But the results was variable in among different cancer patients, and also the mechanism was unknown at that time. So this approach was not widely accepted in the medical community at that time. In the next several decades, research has greatly increased our understanding about the immune system and also cancer immunology. Now we know that there are positive signals, such as the T-cell receptor signal, that can activate T-cells to kill tumor cells. And also we know there are negative signals, such as the CTLA-4 receptor, PD-1 receptor, and the PD-L1 ligand. So those are the negative signals that inhibit T-cell activation. Those negative regulators are called immune checkpoints. And now those immune checkpoints serve as a very important therapeutic target for cancer immunotherapy. In 1996, Dr. James Allison proposed the idea to enhance anti-tumor immunity by CTLA-4 blockade. So his research group used an antibody that blocked the CTLA-4 receptor and demonstrated that the CTLA-4 inhibition can reduce tumor growth in mouse tumor models. Based on those scientific discoveries, pharmaceutical company has developed a monoclonal antibody against CTLA-4 and other immune checkpoint regulators. One of the antibodies called ipilimumab. So it is a anti-CTLA-4 receptor antibody. Clinical trials show that ipilimumab can improve survival in patients with metastatic melanoma, a disease very difficult to treat at that time. And another line of research in Dr. Tatsuko Honjo's lab identified PD-L1 receptor, PD-1 receptor, which is another very important immune checkpoint regulator. And later on, he and his collaborators also identified the ligand for PD-1, PD-L1, and they also demonstrate that by inhibit either PD-1 or PD-L1 by antibodies or by gene knockout, they demonstrate that those inhibition can reduce tumor growth in mouse models. Again, based on those research findings, pharmaceutical company develop monoclonal antibodies against either PD-1 or PD-L1. And clinical trials show that those antibodies are beneficial for cancer treatment. Like in this clinical trial, nivolumab, which is a anti-PD-1 antibody, can prolong survival in advanced lung cancer patients when compared to like conventional chemotherapy. And when PD-1 antibody and the CTLA-4 antibody combine, they can achieve even better therapeutic effects. As shown in this clinical trial, the combination of nivolumab and ipilimumab can prolong overall survival in advanced melanoma patient, as shown here. And now, with this combination therapy, more than 50% of patients with advanced melanoma can survive more than 5 years, which is a huge achievement. And this combination therapy can also prolong survival in advanced lung cancer patient, as shown in this clinical trial. this combination is of immunotherapy is superior to conventional chemotherapy. For their contribution to cancer immunotherapy, Dr. Ellison and Dr. Hangzhou received the Nobel Prize in 2018. And like many other cancer treatment, immunotherapy also has side effects, mainly due to the overactivation of the immune system. Inflammatory and autoimmune side effects can occur in essentially any organ systems, such as pneumonitis in the lung, skin rash, thyroiditis, and colitis in the intestine. Several years ago, we, in collaboration with Dr. Paul Walker, we start a research project to identify biomarkers and therapeutic targets to mitigate immunotherapy side effects and try to improve cancer immunotherapy. So those side effects, as mentioned, it can occur like in any organ systems. Sometimes it can be very severe, even life-threatening, and can cause like a immunotherapy discontinuation. So there is a urgent need to identify biomarkers and therapeutic targets that can mitigate those side effects and to further improve immunotherapy. So what we did is we collect blood samples from lung cancer patients treated with immunotherapy at the baseline and also after each cycle of immunotherapy. And we also isolated plasma from the blood samples for measuring cytokine levels, and also isolate CD4 positive and CD8 positive T cells from the blood samples, and also determine the cell counts. And then the cytokine levels and the T cell counts were correlated with observed side effects. So this patient developed a side effect, neutropenia, when treated with immunotherapy. So the number of neutrophils in the blood was substantially reduced by this side effect. And what we observed that compared to the baseline level, several cytokines significantly increased during the event of irAES, particularly interleukin-6 is substantially increased at the irAES events, and then reduced post the irAES. Some other cytokines, IL-10, IL-7 also shows increase during the irAES events. And also the cells, the CD8 and CD4 T cells compared to baseline, the T cells increased before the irAES event. And then during the irAES, the patient was treated with corticosteroids for the symptom management. That corticosteroid treatment substantially reduced the T cell counts. So that may have some effects on the immunotherapy efficacy. So, and in another patient, so this patient developed three episodes of pneumonitis secondary to immunotherapy. It's here, here, and here. We also observed that compared to the baseline, the CD8 and CD4 T cells increased substantially during the irAES events. And also the cytokine like interleukin-6 and interleukin-10 increased during the side effect events, the irAES events. So that suggests that those immune cells and the cytokines can serve like biomarker during the side effect events, those either pneumonitis or neutropenia and other irAES events. And some of the markers can also potentially serve as a therapeutic target for the management of these side effects. One study led by Dr. Walker and Dr. Straw used tocilizumab, a anti-interleukin-6 receptor antibody, to manage side effects associated with immunotherapy. So here, as shown in this figure, so compared to the baseline, the inflammation marker is increased during the REE event. And after tocilizumab treatment, so this inflammation is significantly reduced. And also the overall survival of patients who are responsive to tocilizumab treatment is much better than the non-responders. So all those studies suggest that the peripheral blood, the immune cells, and the cytokine levels can potentially serve as a biomarker and also potentially serve as a therapeutic target to manage immune-related side effects. And next, I'd like to discuss another potential biomarker in therapeutic target. That is the pro-inflammatory receptor GPR4. So GPR4 is highly expressed in vascular endothelial cells and serve as a gatekeeper to regulate leukocyte infiltration into inflamed tissue. So we and other researchers have shown in multiple animal models, the inhibition of GPR4 can alleviate inflammation in the colitis, COPD, arthritis mouse models, suggests that the inhibition of GPR4 may have some therapeutic effects to manage the inflammatory disorders. And we also demonstrated in a mouse model that the inhibition or deletion of GPR4 can alleviate intestinal inflammation and also tumorigenesis in this mouse model. So compared to the wild type mice, the GPR4 knockout mice show a reduced intestinal inflammation, also reduced polyp and tumor formation in this mouse model. And also interestingly, in the tumor developed in the mice, those colorectal tumors developed in the mice. In the wild type mice, there are a lot of blood vessel formation, it's called like angiogenesis in this wild type tumor. But in comparison, in the GPR4 knockout tumor, the blood vessel formation or angiogenesis is significantly reduced. And now we are investigate if inhibition of GPR4 can reduce the immune-related side effects and improve cancer immunotherapy. So the rationale for this line of research is that GPR4 expression is increased in inflamed tissues. Inhibition of GPR4 has anti-inflammatory effects, and inhibition of GPR4 can reduce tumor blood vessel formation, which can potentially enhance cancer immunotherapy. And finally, in the middle of like this COVID pandemic, so this is very relevant. We in biomedical research very often that knowledge learned like from one disease may have applications in other diseases. So in this example like of the interleukin-6 receptor antagonist, we have just discussed for the management of immunotherapy side effects. A recent clinical trial, actually just several trials, showed that interleukin-6 receptor antagonist provides some survival benefit in critically ill patients with COVID-19, as shown in this figure. So compared to the standard care, the treatment with interleukin-6 receptor antagonist can increase survival in this critically ill patient with COVID-19. And as another like pro-inflammatory receptor, we are also doing research to investigate if GPR4 can serve as a therapeutic target for COVID-19. As mentioned, that GPR4 has a pro-inflammatory function. It can regulate many aspects of COVID pathophysiology, such as leukocyte infiltration, blood clot formation, tissue edema, angiogenesis, and pain. We are very interested to study if GPR4 inhibitors can provide any benefits for COVID complications in animal models first. With that, I'd like to acknowledge lab members, Mona, Justin, and Jude, who are involved in the biomarker study, and Dr. Don Sandley and Krusen involved in the GPR4 study, and also wonderful collaborators, Dr. Paul Walker and this biomarker study, Dr. Sharma, and also the former fellows in our program who have been supported by the Lung Cancer Initiative, and also the grant support like from Lung Cancer Initiative and also other sources. With that, I'd like to thank you for your attention, and I'd like to or be happy to answer any questions that you may have.
Wonderful. Thank you so much, Dr. Yang. This is all really great information, and it's exciting to see how many of your fellows that have been supported by Lung Cancer Initiative on this closing slide too. So yeah. Thank you for your continued partnership. Okay, well, we will answer questions at the end after Dr. Jarrett Johnson's presentation. So I will go ahead and pass it off to her, if you don't mind stopping your screen share so we can let her share her slides. Great, thank you. Okay, Dr. Jarrett Johnson, take it away.
All right, let me get this one going. Here we go. Just gonna move my little square down here so I can see everything. So I'm going to present today one of the, well, actually the study that I did based on the funding that I received from you guys. And so we have a little bit more to go, but we have the basic analysis done. And I think it came out very interesting. So the title of the study was the comparative analysis of lung cancer treatment in a local and national sample with lung cancer. And the reason we wanted to do this is all of my research focuses on health equity within the lung cancer population. So I look at differences between people that live in rural areas, people that live in urban areas, typically marginalized communities, and things like that. So we wanted to see how some diverse parts of Eastern North Carolina, you know, compared to more national samples that were not as diverse. So what I'm going to go over today, I'll talk briefly about the significance and why this study was important. I'll tell you what our research questions were. I will go over the different methods that we used, the results that we came up with, and then the conclusions that we can draw from this study. So first off, I want to give a huge thank you to the Lung Cancer Initiative of North Carolina for funding this study. It was a lot of data and very time-intensive analysis, and we could not have done this without your support. So thank you so much. So just for a little bit of background and where we're coming from in this study, there is a screening recommendations that exist for high-risk individuals that may potentially develop lung cancer, and they just recently changed. But what the new guidelines are, if you're 50 or over, or if you have a 20-year PAC history of smoking or more, they suggest screening you with a low-dose CT every year to try to catch lung cancer in its early stages, because we know a lot of times people aren't diagnosed with lung cancer until they are already have advanced disease. So what established this screening guideline was the National Lung Screening Trial. And one of the studies came out, said that the overall mortality was higher for Blacks in the study than for whites. And we started thinking about the demographics of Eastern North Carolina, and we wondered, was there really a difference in our local sample in Eastern North Carolina? How might this compare to this giant national sample that they used for this screening study? And then finally, we wanted to consider like what possible factors might be contributing to some of these differences. So previous studies had said that disparities may be contributed to sociodemographics or clinical characteristics and potentially the treatment that was received. So as previously mentioned, Eastern North Carolina is more racially diverse than a lot of other parts of the country. And when you look at published studies in lung cancer, what you'll see is that the type of diversity in Eastern North Carolina is not often reflected in other published studies. So sometimes it can be difficult to draw conclusions from those studies that are predominantly white and from urban areas. It's hard to see how those results might translate into a population like Eastern North Carolina. And so, we wanted to look at factors that might influence disparities. Those things need to be explored. And the findings from this, if there were differences, can possibly contribute to more personalized approaches to lung cancer care. So we had 3 different primary aims in the study that we proposed. The first one was to explore potential disparities in lung cancer treatment received, so surgery, chemotherapy, and radiation, between whites and Blacks who were diagnosed with lung cancer in Eastern North Carolina. And then sort of our comparative sample was the National Lung Screening Trial, and anyone in that trial that went on to be diagnosed with lung cancer. So the second aim was to explore potential disparities in mortality and treatment received between whites and Blacks who were diagnosed with lung cancer in the National Lung Screening Trial. And finally, we wanted to, compare demographics and the treatment received and the overall mortality between the sample recruited for the National Lung Screening Trial and those in our database with lung cancer from Eastern North Carolina. So what we did was a retrospective cross-sectional design. So we used 2 sources of data, the electronic health records from the Leo Jenkins Cancer Center, and then we requested access to the data for the National Lung Screening Trial. What we did for the data from Eastern North Carolina is we went back a few years, beginning in 2016, and we collected data on 400 individuals that were newly diagnosed with lung cancer in that time frame. And we decided to go back a few years because we needed to be able to examine the mortality of these individuals. And so we needed to let enough time lapse to see, who would still be alive and who would not still be alive at the time of analysis. And so the different variables that we pulled in both sets of data, we looked at demographics, so gender, age, things like that. We looked at the type of lung cancer treatment that people received in both of the samples, so surgery, chemotherapy, and radiation. And finally, we looked at the mortality data, so how long someone survived from the time of diagnosis. To analyze the data, we used basic descriptive statistics, we used logistic regression, we used some equivalence testing, and finally for the mortality, we used Cox regression analysis. So just briefly, I wanted to go over the demographics in both of the samples because they were in fact, very different. We can, go back and forth between the slides later if anybody has more questions. But as you can see in the sample from Eastern North Carolina, 32% of the sample was African American. And so this is not something that you often see in published studies that look at lung cancer. The age, mean age for each group for African Americans was, 65. For whites, it was 69. And that's something that you will often also see with lung cancer. Those in marginalized populations are often diagnosed a little bit younger. So we had, these are all within the columns here, by the way. So among African Americans, 11% of the sample were women, 20% were men. This is the overall breakdown. And then you can see for the whites. So then here's what we have in terms of treatments. Who received what? So in our sample from Eastern North Carolina, 20% of African Americans received chemotherapy, 17% received radiation, and 60% received some type of surgery. And so, oh wait, I went over one, sorry. Chemotherapy, 60%. Sorry, guys. 60% of African Americans in the Eastern North Carolina sample received chemotherapy. 36% received radiation, and only 1.5% received surgeries. You can see it's only 2 people. So among whites in our sample from Eastern North Carolina, 43% received chemotherapy. 34% received some type of radiation, and still a very small percentage received surgery. And a large reason we'll look in a few slides is because of the stage of diagnosis. So when we compared this to those that were diagnosed with lung cancer in the National Lung Screening Trial, it's a little bit different. Here you can see a lot more people had surgery, whether they were Black or whether they were white. And one of the reasons for that is because, the purpose of the screening trial was to catch lung cancer as early as possible. And so when you catch it at an earlier stage, surgery is often, an option for treatment, where if you are diagnosed at stage 4, it's often not an option. So here's what, I was really interested in looking at, what stage was everyone diagnosed from Eastern North Carolina, and what stage, were individuals diagnosed with lung cancer in the National Lung Screening Trial. And so you can see from this, just looking at the numbers, more people were diagnosed with early stage disease in the lung screening trial. So it was definitely doing what it was supposed to be doing, and catching lung cancer early. And then you come down here to stage 3B and 4, and you can see a much higher percentage of the sample from Eastern North Carolina is diagnosed with late stage disease. So when we got in there and compared the 2 groups, first we compared the data from Eastern North Carolina. And what we found were there were no differences between the racial groups and who received chemotherapy and who didn't. The same thing for radiation. There was no difference between Blacks and whites in terms of receiving radiation as a type of treatment. And finally, the same thing for surgery. There was, no difference between the racial groups, but there were so few individuals who received surgery in Eastern North Carolina. These results weren't very stable. We can't, draw a big conclusion from 9 people. So, and then when we looked at the National Lung Screening Trial, we found pretty much the same thing. When we looked at who received chemotherapy, there was no difference between the 2 racial groups. When we looked at radiation, again, no difference. And finally, surgery, they had a much larger sample that had received surgery. There was, no difference between the groups. Next, we examined mortality. So the good news is there were no significant differences in either the Eastern North Carolina data or the National Lung Screening Trial in mortality. But this is just analyzing it, within each data set. And then what conclusions can we possibly, reach from this? One, there's no difference in the treatment received between Blacks and whites, and there's no difference in the mortality between Blacks and whites in each of these samples that we analyzed. Some of this could be due to a lack of power to detect differences, especially when you look at how small the number of individuals that received surgery is in Eastern North Carolina. One thing that we have been thinking about, myself and my co-author, is that the national screening guidelines were already in place when we started to collect the data from Eastern North Carolina. But what we see is, even though the individuals in Eastern North Carolina should have been screened according to these guidelines, there were still a lot of individuals diagnosed at a late stage disease. So now we have to think, what might be causing that? Why are we not catching people earlier in the process of lung cancer in Eastern North Carolina, like they were able to do in the screening trials? And, there are a lot of factors that could play into this. Access to healthcare, access to a primary care provider, financial reasons, living in a rural area and the distance to travel to more specialized centers like the cancer care. So all these are things that we have to start thinking about for future studies in this area. So the next steps that we're planning on taking for the publication, we're going to go through each variable that we looked at and find out which ones we can, compare exactly and see if there are differences between the two samples. And one of them would be stage at diagnosis, and another one we're considering is mortality. And then for future studies, we want to potentially examine the time from diagnosis to the first date of treatment in the two different samples and see if there's any difference. And if, being in a place like Eastern North Carolina, does it delay your treatment at all? Hopefully not, but we know there's something else going on there that's delaying the screening, so we just need to sort of investigate that. And so that was another idea for a future study, examining the screening practices in Eastern North Carolina, understanding more of what the barriers might be for high-risk individuals that aren't getting screened early, and see if we can come up with some interventions to promote screening in the region. All right, so thank you very much. And I guess we'll take questions for both of us. I'm going to stop this. There we go.
Great. Well, thank you so much, Dr. Jarrett Johnson. That was a great presentation. Very thought-provoking. I have a couple questions myself, but I encourage everyone who's logged in here, submit your questions in the Q&A box. I don't see any in the Q&A box right now, so maybe I'll kick us off with one of my questions and give folks a time to submit their questions there. So this is for Dr. Jarrett Johnson. Big thing that we're talking about in the world of public health and clinical research right now is improving diversity within clinical research, medical research, all of those types of things. And that's like your whole area. So what do you suggest as kind of starting steps to increase those numbers, to make sure that the clinical research that we're conducting can be applicable to more diverse groups of people?
I think one of the biggest things is reaching out to the communities before you begin studies and building strong relationships and maintaining those strong relationships. A lot of what I do is not so much like drug trials or clinical trials. So we're looking more for interventions to make people feel better. That's what we do in nursing. And so one of the most important research methods to look at is community-based participatory research. And that's including the community in the design of the intervention and in the design of the study, so that the needs of the community are being met, and that the questions that they have for their own community is what you're looking at when you're doing research.
Great, thank you. Jenny, do you have any questions that you would like to ask of Dr. Jarrett Johnson or Dr. Yang?
Dr. Yang, I was going to ask you, with your research studies, do you have problems recruiting participants in Eastern North Carolina, or how does that look? I'm just curious to see if you have any issues, or, you know, if you know how diverse your populations are normally in the trials that you do.
Well, right now we are in the middle of a pandemic. It's difficult to recruit patients. But before that, with the great help and collaboration with our oncologist, actually we recruit patients pretty well. Yeah. So initially we set for the 20 patients as a goal. And we achieved that, and then the patient also were very supportive of the research. So they the baseline, and also after each cycle of the immunotherapy. So we collected the blood sample, and also get the nurse involvement is also very important. So they do the blood draw, those aspects, and also have interactions with our clinical trial office. So that the experience was actually very positive for our study, and we recruit both white and African American patients in our study. Yeah, so that I think it's a pretty good involvement. Yeah.
And do patients have to go to Greenville, or can they go to another Vidant site?
For this particular one, all patients are seen in Greenville, ECU or Vidant, because for the blood sample, we need to get the blood sample immediately after it was drawn. So that for this one particular study, yes, it's in Greenville. But in the future, I think it's very possible that the blood sample might be drawn in other sites and then sent to us. That's certainly that's possible. Yeah.
Great, thank you. Well, we had a couple questions come in. So this one is for Dr. Jarrett Johnson. How much do you think health literacy plays a role in the Eastern North Carolina area and the patients in the area? If it does play a role, what do you think the answer is to improve health literacy?
So I don't do a lot with health literacy, but I do think it's a problem, not just in Eastern North Carolina, but just across the US in general. If you're not, very familiar with the medical system, it's very difficult to speak the same language as the doctors and nurses, and they're giving you this information with all these big words, and you're trying to process a new diagnosis and everything. I think what we can do is, as clinicians, become better at how we talk to people, relate to people, just become better about how we deliver the information to them, making sure we're doing so in a way that everybody can understand it. So for some people that might be written material, if there are just literacy or other language issues, also having video type material that you can use, some things that you can just listen to. Like, everybody learns in a different way. And so I think really expanding the ways that we deliver information to try to meet more learning styles would help. But again, health literacy is not my area. So that's just my own personal opinion. So.
Great, thank you. Okay, this question is for Dr. Yang. Are there any known drugs to target GPR4 to reduce irAES?
Well, there's some GPR4 inhibitors in the preclinical study, so that have been developed by pharmaceutical companies such as Novartis, and also there are some company in Japan. So they have developed a small molecule inhibitors. So those have been evaluated in preclinical animal models. So not in the clinical trials yet. And then for the RE aspects, to my knowledge, we probably will be the first group to evaluate the GPR4 inhibitors in irAES animal models. Yeah, we are very excited to do that, and you know, to try to see like what would be the effects from the GPR4 inhibition.
Great, thank you. Okay, I think this is probably directed at Dr. Jarrett Johnson, but Dr. Yang, if you have any thoughts as well, I would be happy to hear it. This question is, how do you go about getting input from patients when developing a study protocol or informed consent?
So ideally, before you even start to form the study, you would be out in the community, meeting with church groups, meeting with cancer survivorship groups, working with partners like the Lung Cancer Initiative of North Carolina to be really involved in the community before you even start to design your study. And then at the point that you're ready to start your study, you invite some of the community leaders to join you at the table when you're talking about the study protocol. And that includes everything from how you're going to recruit. The leaders in the community are going to know that their particular community better than you ever will, because they're part of it. So they will be able to tell you need to recruit here, here, and here. And then you can listen to, the problems that they're having. So when you're designing your study, you're designing it with the input, of these community leaders. So let's say you wanted to look at barriers to lung cancer screening, and you were just going to make that study and go out and recruit people. But your community leaders might have a very different thing, like, well, it's not just all barriers, it's money. So can you please, ask about money in your study, or find out how financial barriers are primarily influencing, the inability to get screened, something like that. Informed consent always goes through the IRB. So they have different forms that you can use. You can do signed informed consent, which is a longer process, but in some other studies and populations like the Latino population, you can sometimes request a waiver if that's going to be the only connection that participant has to your study, just to further protect that community. And you can do a verbal consent instead.
Great, thank you. Okay, and Dr. Yang, do you have anything to add to that? I don't know how much you involve community feedback in the work that you do.
I rely heavily on our physicians and nurse, to do this part. But we, similarly, the study went through the IRB approval and the informed consent. All those form went through the IRB approval. So I don't know if there's any physicians or nurse from ECU in the audience, if they have anything to add.
Yeah, if they do, throw it in the chat box and share with us. I would be curious to hear. Okay, well, I think I have one last question for you, Dr. Yang. I'm curious, you were talking about sometimes the implications of your research goes beyond lung cancer, and using COVID-19 as an example. Are there any opportunities for your research to be applied to other different types of cancers specifically? Are these pathways, do they align with different types of cancer, or is it very specific to lung cancer?
It has applications in other cancers as well. So like the one cancer type very interesting is the colorectal cancer. So we already have some preliminary results in the animal model in that the colitis associate the colorectal cancer model, so that the inhibition of GPR4 can reduce both colitis and also the tumor formation in this mouse model. So in the patients with colitis or informed bowel disease have a high risk of developing colorectal cancer. So that certainly would be one aspect we're kind of very interested to look into that. Also, it also speaks to the wonderful work you guys are doing. So although you are focused on the lung cancer, but some of the study from the knowledge learned from the lung cancer can also apply to other cancer types, or even in other diseases such as the COVID-19 just mentioned. Yeah. So really, you are doing a great work, yeah, and thank you for your efforts. Yeah.
Well, thank you. Thanks for sharing that. I appreciate that. And I've actually learned recently, biomarker testing has become the standard of care for lung cancer. And I've just learned recently how some of the biomarkers for lung cancer also apply to other cancers as well. So it's really exciting. Well, I did just get a question in here from a comment from a nurse, actually. She said, I am a research nurse with oncology clinical trials. There is much great work to continue everywhere on including the community to be engaged in clinical research protocol development. So always room for improvement, but it helps when we have partners like you all to work with, and we're all doing it together. So that is it for the questions that I've received, and I think a good positive note to end on. So thank you, Dr. Jarrett Johnson and Dr. Yang, for your time and your partnership. Really exciting to hear about the work that you all are doing today. Paige, do you have anything you'd like to add as we wrap up?
No, I think that was excellent, and just appreciate you sharing that with us. And thank you to all of you for your questions and for joining us today.